Hello, and welcome to the Mayo Clinic Cardiovascular Interviews with Experts podcast. I am Greg Barsness, an interventional and critical care cardiologist at Mayo, and I'm thrilled to be joined here by Dr. Fahad Shuja, assistant professor in the Division of Vascular and Endovascular Surgery at Mayo Clinic Rochester, Minnesota, in the USA. Fahad attended medical school at the Aga Khan University in Pakistan. He ultimately underwent general surgery residency at the Mass General Hospital in Boston, followed by fellowship in vascular surgery at the Beth Israel Deaconess Medical Center, also in Boston, and then had an advanced endovascular aortic fellowship at the Klinikum Süd in Nuremberg, Germany. Fahad's research focuses on the role of senescent cells and macrophages in atherosclerosis. And as practice chair in vascular surgery, he is using this vast clinical and research experience to expand the limb salvage program at Mayo Clinic here in Rochester, centered on the multidisciplinary collaborative care of these patients. Welcome, Fahad.
Thank you very much. Happy to be here.
It's really a pleasure to be talking with you. I think we'll jump right in. The prevalence and clinical impact of peripheral arterial disease, your specialty, is having increasing impact in our care of patients and in the recognition of disease substrates and how these patients are best cared for. Given this increase in the clinical impact, what can you tell us about what's being done, what has been done as far as research and clinical care of patients with peripheral arterial disease?
Absolutely. And thank you for that question. I think it sets us up nicely for the topic of the podcast today. So peripheral arterial disease affects over 200 to 250 million people worldwide. And these are the ones who have been diagnosed. I'm sure there's many more who don't know they have peripheral arterial disease. These patients have severe cardiovascular medical conditions and have multiple hospital admissions and both surgical and endovascular needs. Critical limb threatening ischemia, which is the more severe form of peripheral arterial disease, carries the second highest mortality for a diagnosis after pancreatic cancer. It is also the second leading cause of mortality in the world in numbers after lung cancer. So clearly the impact is vast, and that is specifically the reason why multiple specialties have invested hugely towards understanding the pathogenesis of peripheral arterial disease and trying to identify best forms of treatments. Now, briefly about that, there is the optimal medical therapy, which includes anti-hyperlipidemics, antithrombotics, dietary protocols, control of cardiovascular risk factors, having an active lifestyle. And then there is the ever hotly contested subject of revascularization. And I'm sure we're going to talk about that later in this session. But timely revascularization remains the number one predictor of limb salvage in patients with critical limb threatening ischemia, whereby in the absence of a timely revascularization, the annual incidence of major limb amputation could be anywhere up to 25%. And these are patients who not only reap the cost of their own health, but their families suffer psychosocial burden of caring for these patients. So I think the subject is very important for all of us.
So that's very interesting. So I'd like to go back to the medical issue, because medications, while they're important, and obviously across the vascular bed, across the vascular tree, we know the importance of good optimal medical therapy as background therapy for event prediction. But CLTI, critical limb threatening ischemia, it can't be cured by medical therapy. So maybe delve into that just a little bit more. You mentioned it, but revascularization is a mainstay of limb salvage and improvement in morbidity and mortality for these patients.
Absolutely, absolutely. I think it is important to understand that while the role of medical therapy cannot be denied, once PAD reaches the stage of critical limb threatening ischemia, which means either rest pain, tissue loss, or gangrene, revascularization becomes critical to salvage the leg, which is the ultimate aim of anybody caring for this patient population. So in terms of revascularization, we have two broad categories of procedures. One is surgical interventions, more commonly known as a surgical bypass. And the other is the area of endovascular procedures, which is an ever increasing list of techniques, technologies to improve circulation, to improve perfusion. It started off in the 1960s with plain balloon-based angioplasties, and then have evolved with the introduction of stents of different kinds. And nowadays, we're going even beyond the subject of balloon angioplasty versus stent angioplasty, going into mechanical and pharmacological lesion modification. So it's a very exciting area of both clinical and basic science research. But yes, you're right. Timely revascularization. Without that, limb salvage is not possible with medical therapy alone.
Well, let's go into that then. So you mentioned two broad categories of revascularization: endovascular and surgical revascularization bypass. Tell us what has been looked at in the past. What's the background for data regarding the relative benefits and efficacy of those therapies, and what's been developed, what's been understood more recently?
Yeah, that is an area where level 1 randomized clinical trials have unfortunately really lagged behind. When you compare to some of the burning questions in the coronary space, we have a plethora of really high quality data to guide our treatments, endovascular or open. With peripheral arterial disease, and specifically with critical limb threatening ischemia, we don't have that many level 1 randomized clinical trials to tell us which is the better way to treat. Before the BEST-CLI trial, which I know will be a subject of our conversation today, Greg, there was the BASIL trial, which was performed across 27 different hospitals in the UK in the early 2000s. This was a bypass versus angioplasty in severe ischemia of the leg trial, a BASIL trial. So over 450 patients across 27 hospitals in the UK were randomized to bypass surgery or balloon angioplasty. Now, again, this is early 2000s, so we did not have the kind of advanced endovascular tools that we have up our armamentarium today as we did back then. So balloon angioplasty was pretty much it when it came to endovascular techniques. And the trial had some interesting findings. When they first published their data, about 2-year follow-up, they did not find any significant difference between the two approaches when it came to amputation-free survival or overall survival. The group then went on to publish another follow-up where now they extended the follow-up to up to 5 to 7 years, and they found that patients who survived beyond 2 years, there was a trend towards improved amputation-free survival or overall survival in the surgical bypass arm versus the balloon angioplasty arm. So again, not exactly level 1 data, but at least it gave us some idea of the long-term superiority and benefits of bypass surgery compared to endovascular surgery. Again, remember, this is early 2000s, and endovascular treatment is limited to balloon angioplasty only.
Yeah, very important point. And so now we do have more recent data available to us using more contemporary techniques, both for surgical revascularization and endovascular revascularization. The best data we have to date is, in fact, referred to as the BEST-CLI trial. Maybe you can tell us what this trial was meant to demonstrate and what it found.
Absolutely. Yeah. So recognizing the lack of clarity on the relative advantages and disadvantages of the two treatment modalities, the BEST-CLI was a prospective randomized study done across 3 continents in patients with critical limb threatening ischemia. The trial had originally anticipated enrolling 2,100 patients, but due to financial reasons, funding reasons, they ended up enrolling 1,830 patients. It essentially was 2 separate prospective randomized trials, Greg. So cohort 1 was patients with critical limb threatening ischemia who had adequate length of their saphenous vein to be used for a bypass conduit purposes. And cohort 2 was one that lacked that single segment saphenous vein conduit. Now, to qualify to be enrolled in the study, two separate physicians versed with both open and endovascular techniques had to agree that the patient would be considered for either approach in their institution, in their hands. And that was a prerequisite to be considered. So to summarize, BEST-CLI, patients with critical limb threatening ischemia who would be considered for either approach, open or endovascular, were then randomized into cohort 1, which included patients with usable, usually long enough great saphenous vein, and cohort 2, which did not have suitable saphenous vein conduit, and you would have to rely on alternative conduits like a cryograft or a prosthetic graft. That ended up being cohort 2. And then they were followed for a median of about 2.7 years in cohort 1 and 1.6 years in cohort 2. And the primary outcome of interest was a composite outcome, and that has to be said. It was a composite outcome of major adverse limb events, which was defined as amputation above the ankle or a major limb reintervention. And the reintervention could be defined as formation of a bypass graft or revision of a graft, thrombectomy, thrombolysis, and death. So composite outcome was death and then major adverse limb events.
That's terrific. So a complicated trial. So I think I remember 5 years of enrollment, didn't quite meet pre-specified enrollment levels, but did have some really fascinating findings and I think important findings. So that leads to the question, how can we interpret this data in the context of our clinical practices? How do we bring this to bear on our patients, and what might be available for the future?
Yes, I think BEST-CLI is here to stay. It is now published data, and I think we have to dive deep into the patient populations. The trial strategists did a good job at pre-selecting cohorts like patients with predominantly infrapopliteal disease versus femoropopliteal disease, patients with chronic kidney disease versus not, diabetes versus not. So I think we should stay tuned for more publications by the BEST-CLI group, trying to understand, what is it about critical limb ischemia, this patient population, at least in the trial, that lent itself poorly to endovascular therapy. Was it about patient selection? Was it about treatment selection? Is it a treatment bias and a procedural risk bias? Those things will, I think, take time to pan out. But in my offline communications with the trial committee, there is every effort to dissect the data out, piece by piece, bit by bit. So that is very encouraging that there's more to learn from this trial. And then I think it really points to the value of screening for venous conduits in patients with critical limb threatening ischemia. I think there is data out there that roughly 25 to 40% of CLTI population, especially the Hispanic and the Black population, do not get vein mapping prior to having a major leg amputation. Right.
And is that a cost issue, or is it a style issue? Is it?
I think it's failure to recognize the value of surgical bypass. I think over time, this is the pendulum continues to swing from one end of the procedure spectrum to the other. So I think BEST-CLI, if nothing else, it really re-emphasizes the value of an appropriately performed bypass with good conduit. There have been all sorts of concerns about the morbidity of a bypass, the mortality around a bypass. And at least in BEST-CLI, we find that is not the case. The major cardiovascular post-operative events were identical, not statistically different. So I think that's a big takeaway, that patients with critical limb-threatening ischemia need to be evaluated for presence of venous conduit. And if so, then we need to assess their surgical risk. We found out that, at least in the first publication, the authors did provide some clue as to what's to come, where they said that across multiple patient subcategories, this superiority of bypass versus endovascular prevailed, except patients over the age of 80, patients with chronic kidney disease, patients with a prior ipsilateral revascularization. So I think that we should not see, or at least I don't see BEST-CLI as choosing between surgery and endovascular. I think they should not be seen as contradictory to each other. I think they should be seen as complementary to each other. And I think that's what we need to wait until further data comes out, is who were the patients that exhibited a high rate of endovascular failure. What was it about them that led to that high failure rate? What can we learn from them? And vice versa for surgical group 2.
That's great. So a lot left to learn. So we've learned a lot. We understand the safety and feasibility of these procedures, I think, in expert hands with good experience, with proper pre-procedural planning. I think both of these procedures can go well, especially with the newer tools and techniques available. And with just 1 minute to go, I think, what do you think the future does hold? So revascularization is important. What can we do beyond that? What are the possibilities?
Well, I think we live at a time where I can't drive from work to home without hearing about ChatGPT. So I think we are getting more sophisticated with data collection as well as data review and data translation. In my opinion, we're going to start treating CLTI patients like patients with cancers. We're going to have to account for lesion length, lesion location, lesion type, calcification versus fibrosis. And then individual treatment paradigms will develop with that data review to suit individual patients, where if you have a 50 centimeter severely calcified lesion involving the popliteal and tibial arteries, we might find out that surgical bypass is the better way to go. And there's no sense in trying endovascular procedures because they're unlikely to give you durability, versus a patient with a 50 centimeter femoropopliteal lesion that is largely thrombotic/fibrotic. Endovascular will have a shot. It might end up being a cost-effective strategy. So when it comes to the future, I think we have to understand the biology and the physiology of individual lesions. We also have to understand our own capabilities. I think every institution needs to take a look inside and look at its own technical success rate, conversion rate of endovascular and open, and then use that to offer the best treatment for our patients so that we can save them from unnecessary procedures.
That's terrific. So I think that the future does look bright. A lot of new opportunities evolving, a lot of new strategies. AI is certainly going to play a role in revascularization selection as well as additional new therapies. And I, for one, join you in being very excited about the future. So, Fahad, thank you very much. On behalf of of the rest of our Mayo Clinic colleagues. I appreciate your willingness to discuss this, and I want to thank everyone for their attention.
Thank you very much. It was a pleasure to be with you, Greg.